Hey Doc, Bernard Jen here. Hope you're having a good day. Just want to share with you a common case that we get at our office that gets referred to us all the time. And here goes. So the patient shows up, a gentleman. Basically, he reports that he's had this implant in his mouth for the longest time and he lost the crown. In fact, the crown came off. It's in his hand. And I'm looking at it going, okay, great. Let's have a look inside your mouth. And yep, I could still see the abutment through the gum. It would look like a stock abutment. And then I send the patient for a CBCT analysis. So we take a CBCT scan and we look at the sectional slice. And yeah, that looks like a decent amount of bone. There's a little bit of crestal bone loss, but that's typical of this kind of implant design. It's a conical type connection, but it had micro threads around the implant, and thus, the crestal bone loss is typically what we see, generally self-limiting. And so we go ahead and look at it, and yeah, it looked relatively normal. And then we proceed at taking off the stock abutment, and this is what the site looks like. Yep, internal connection, make sure we had the right healing abutment that fits in there, and we did. And then we told the patient, yep, we could certainly do that. He's asking if we can re-cement his old crown. And when I look at his old crown, basically there was a crack through parts of it. And I'm going, well, it's not going to work. The zirconia is not going to fit, or the zirconia part's going to fit on the temporary abutment, but it's not going to work out. It's not going to stay there. So I talked to the patient and said, sure, I could probably provide you with a new crown. You can still keep the implant, but there's some limitations. You'd probably need to go through a temporary or provisional stage because this happens to be a free end implant. It's a last implant in the patient's jaw, which means we have to factor in the bite forces, the way the patient occludes, and factor in any kind of give or relief that we need to build into the system when we give him his final prosthetic. In addition, the soft tissue, I looked at it, and it was all mucosa. And we're saying, well, that soft tissue is not exactly the healthiest. And so what we'll need to do is we'll have to do a free gingival graft plus vestibular deepening. And so basically that's what we did. We took an impression. You can see the crestal bone loss. This is closed tray impression coping. That's all that we had at the time. I took the impression. This verifies the seating of the impression coping. And after we've done that, we go ahead and fabricate the patient a PMMA crown. Now you'll notice this image is after we've delivered the PMMA crown and we have performed a free gingival graft. Those sutures that you see over there, those are the sutures that I place to do the vestibular deepening process. As many of you know, when it comes to lower molars, the external oblique ridge, and you have your insertion point for your buccinator, and it's quite muscular in that area, so we have to factor those parts in. So we go ahead and we had harvested the free gingival graft from the tuberosity because I like choosing the tuberosity because it's usually less painful for the patient. And this is the healing site approximately 2-3 weeks after the procedure. And you can see it's healing quite unremarkably, and the patient seems very comfortable. You can see the stains from the chlorhexidine use, and that's usually what we do. We tell the patients to use chlorhexidine. So this was the delivery of the PMMA. You can see we still are using the stock abutment for the PMMA, and this is to prove that it's fully seated. And then I just wanted to show the development of the keratinized tissue on the buccal aspect and the suturing of the vestibule. It's so important to suture the vestibule down. That way you can develop the nice keratinized tissue. And that's what it looks like after you take off the provisional abutment, provisional crown. And that's a nice thick band of keratinized tissue. After we've done that, we've verified it all as well, no sign of pathology. We then take the PMMA and scan it and perform a transfer mount in our lab. And that allows us to then fabricate a definitive crown for the patient. In this case, I spoke to the patient. I was able to convince the patient to utilize a full gold crown because I firmly believe in heavy occlusion that the patient should be fitted with a full gold crown because of the malleability of the material itself. gold is a little bit malleable, it's a little bit more forgiving than hard zirconia. And so that's why I convinced the patient, and the patient was like, yep, I'm going for it. And so we delivered that full gold crown. You can see the nice keratinized tissue, and we verified it. Patient's happy. And yes, I know some of you who are gold enthusiasts, you're telling me that I should be closing that access hole up with gold foil or gold plug. Yes, I realize that can be done, but I always feel guilty if I have to drill through it to either retighten it or do something to it. So we close it up with composite. All right, I hope you had a great day, and I hope you have a great day, and I hope this was an interesting case that you could identify with. Have yourself a wonderful day, Doc. Cheers. That's the final image.